Hi, my name is Matthew Bach, and this video presentation will be used primarily to educate patients regarding the use of injectable corticosteroids to treat symptoms of osteoarthritis. Osteoarthritis is the most common type of knee arthritis over rheumatoid arthritis and post-traumatic arthritis. Osteoarthritis has a slow progression and generally affects middle-aged to older adults and is caused when the articular cartilage wearing down inside the knee joint causes a bone-on-bone grinding action. Signs and symptoms of osteoarthritis include constant pain with weight bearing, kneeling, going up and down stairs, and the associated stiffness and swelling of the knee. Initially, non-steroidal anti-inflammatory drugs, or NSAIDs, such as Advil or Aleve, are utilized to reduce swelling and curb the dull aching pain. However, as the arthritis progresses, sometimes these NSAIDs don't work as well. Corticosteroid injections can sometimes be described as the middle ground between when a patient has arthritis that is not being effectively treated with NSAIDs, but isn't quite bad enough bone-on-bone arthritis to warrant surgical intervention via knee replacement. One of the most popular corticosteroid injections is Solu-Cortef, which is a hydrocortisone sodium succinate injection used to treat arthritis. Hydrocortisone is a corticosteroid, which is a medication that mimics the effects of the hormone cortisol. The mechanism reduces inflammation by limiting the capillary dilation and permeability of vascular structures. These compounds limit the accumulation of leukocytes and macrophages and inhibit the enzymes that attack injury debris in the immune response. Osteoarthritis is a localized condition versus a systemic condition such as rheumatoid arthritis. Therefore, oral corticosteroids are not prescribed as often unless the arthritis affects the entire body. Instead, the injection is used to deliver the medication directly to the location and is performed by a physician or their physician assistant. The healthcare provider will administer the medication in a clinic and will store the product unopened at room temperature between 68 and 77 degrees Fahrenheit. First, the physician or PA will palpate the knee to identify knee anatomy landmarks where the injection will be administered. Then, a betadine soap will be spread over the knee and clean the site where the injection will take place. After this, the lidocaine, which is a numbing agent, will be sprayed because a 25 gauge needle will be used for the injection and can sometimes cause pain in some patients. The dosage for Cortef hydrocortisone is dosed at 100 to 500 milligrams of hydrocortisone prepared in a 2 milliliter solution. The dosage depends on a variety of factors, including the severity of the arthritis or how many injections the patient has received previously. The initial dose will be lower and gradually increased or adjusted based on how well the patient's symptoms are controlled. The patient should feel relief within a few hours, but should refrain from strenuous activity the day of the injection. The day after the injection, normal activities can be resumed. Improvement may last anywhere from a month to even over a year. However, these injections should be performed conservatively and only administered every 6 to 8 weeks at maximum, and the guidelines indicate they should be performed no more than 3 to 4 times per year. This is because the medication can cause injury due to the thinning of joint cartilage, weakening of the knee ligaments, or even subsequent increase in inflammation as the joint capsule builds a tolerance to the medication. The cartilage damage can be described as chondrocyte toxicity. With nearly every medication, there are potential side effects to be aware of. Post-injection flare can lead to the aggravation of the inflamed area as the pressure of the knee capsule is changed with an increase in fluid. The injection site may also become sore or bleed because the skin is being pierced with the needle. The patient should not receive an injection if allergic to hydrocortisone or other steroids. Typically, corticosteroids are very rare, although facial flushing can occur in up to 40% of cases, and they last very briefly. Precautions should be taken with patients suffering from diabetes because the drug may increase the blood sugar levels in diabetic patients. In addition, the steroid can somewhat suppress the body's immune system and possibly worsen or mask a pre-existing infection. These injections are used very cautiously in people with diabetes or bleeding disorders such as hemophilia. An increased exposure to corticosteroids with subsequent injections can also lead to elevation in blood pressure, osteoporosis, and/or thinning of the cartilage within the knee. Patients should be educated of the potential side effects. Despite this list of adverse reactions, with low and intermittent doses of the injection, most patients pose little risk of side effects. Some potential interactions with drugs can include blood thinners such as warfarin that can lead to an increased bleeding with the needle injection or an inhibition of the body's response to the warfarin. Insulin or diabetic medications can also have an effect due to the previously mentioned elevation in blood sugar. Combining corticosteroids with barbiturates can also lead to an increase in cytochrome activity in the liver, which enhances the breakdown of the corticosteroid, leaving it less effective. Combining other NSAIDs or aspirin with corticosteroids may increase the risk of gastrointestinal side effects. However, because the injection is given locally and directly into the knee joint, there are very few drug or diet interactions with this medication. Corticosteroid injections are not for everyone, and sometimes physical therapy to build strength and stabilization of the knee, or in combination with glucosamine and chondroitin supplements, can help alleviate the symptoms, but typically do not address the joint inflammation that causes the pain. In summary, Cortef hydrocortisone injections can be an effective treatment when generic NSAIDs are not sufficient in treating the inflammation associated with osteoarthritis. The medication should be used conservatively to limit any potential cartilage breakdown that may worsen the symptoms. If the patient does not receive any relief of arthritis and the X-ray imaging indicates bone-on-bone articulation of the knee joint, then knee replacement surgical intervention should be considered.